this is your presentation. Okay, استخدم من هون. Yeah, go ahead.
Okay guys, so I'm gonna talk just quick review about sepsis pathophysiology and definition, and the treatment management will be another lecture. So we're starting with the overview for today. We're gonna talk about definition, then the pathophysiology, a little bit about diagnosis and the outcome. So the origin of word sepsis, it came like more than 2,000 years ago, and the Greek people were the first who give the origin of the word, and it means decomposition of animal or organic material by bacteria. Then over years, as we said, like sepsis starting long time ago as a definition, Hippocrates started that with the idea of initial theory of infectious disease. Then after that, other diagram by Lister, Koch, and Pasteur. Then after that, the different meeting of sepsis that came up, and the first one was 1991. Over years, as we said, like since 1860s, when Louis Pasteur gives the first idea about the germ theory. Then after that, in 1992, first meeting for sepsis. Then after that, second meeting, 2001. Then different trials came up with the treatment, and the last one to 2016, the last meeting for sepsis 3. Epidemiology in general, in 1970 in the United States, annual rate of sepsis cases was around 164,000 cases. Then there was like a huge difference after 1979 to 2000, as like annual rate more than 1.5 million cases per year. And it is estimated about 437 per 100,000 person between 95 to 2015. And some statistic showing that's more common among African American males, and it's greater during the winter season, and for older patients above 65-year-old with a percentage above 60 to 85%. So definition of sepsis 1, the first meeting was in Chicago, 1991, and at that time they put a definition as its ongoing process, and they put a criteria of 2 or more SIRS criteria. SIRS criteria, all we know it, is body temperature more than 38, less than 36, or heart rate more than 90, respiratory rate more than 20, and leukocyte count more than 12,000 or less than 4,000.
But go back a little bit. This is very important, the immature forms of bands.
The band cells will be more than 10%.
Bandemia is one of the indications of SIRS that most likely people miss.
Yep, that's correct. And they mention also about the severe sepsis, and they defined it as a clinical sepsis accompanied by organ dysfunction, hypoperfusion, or hypotension. And they put definition for septic shock as a patient with a clinical tableau in which fluid vasopressor resistant with hypotension, and the MAP at that time they mentioned should be 70 or less.
Just stay on this line for a second.
Okay. So what is the deficiency with sepsis 1? So first of all, they give us a criteria for SIRS criteria. SIRS criteria, 2 or more, it could be happened in infection, in any inflammatory condition, because we know it's the first defense of the body for anything is going. It's infection or another things, it will be innate immune response. So the SIRS criteria will be positive in different stuff other than sepsis. Even like simple infection, upper respiratory tract infection, patients will not be septic, but he will like meet the criteria with tachycardia or fever. And the other things, the other example, sepsis-like picture with a hyperkinetic state, especially after the cardiac surgery, which could be without any infection. And if any patient under stress, he will be high with respiratory rate and tachycardia, and at that time will be meet the SIRS criteria. So that's the main deficiency in the sepsis 1. Then in 2001, they gathered again for sepsis 2. Basically, they put the same definition, but they brought the symptoms a little bit with general parameter and inflammatory parameter. But originally they didn't make any big change in the definition itself. It is the same ongoing process, and the SAYS criteria was part of the diagnosis. Then after that, sepsis 3, it came in 2016. So the definition basically changed, and they mentioned it's life-threatening organ dysfunction caused by dysregulated host response to infection. So in this part, they put the basic, that we know it should be like there is organ dysfunction, and it should be severe. And why it happened? Because the host immune response was dysregulated, out of the control. And they put definition for septic shock, that the patient rising in the lactic acid above 2 without hypovolemia, and there is initiation of the pressors treatment to keep mean arterial pressure above 65. And in this definition, they depends on the SOFA for define the patient as septic. So what?
So how would you call someone septic right now?
So
there's no SIRS, right?
No SIRS.
There's no severe sepsis. So we have either sepsis or septic shock.
Right.
What is sepsis? Just to simplify things.
It's organ dysfunction.
SOFA score.
2 or more.
2 or more.
Yeah, I will.
Plus
Possible source of infection.
plus infection.
Yeah.
Source of infection. Suspected source of infection.
Yep.
That's sepsis. Septic shock.
Same.
Pressors and lactic acid above 2.
Lactate above 2
And pressors.
or
So-
needing pressure.
Needing pressors.
Simple.
Yep. So what is the definition in sepsis 3, which can be in the future to adjust on the criteria?
Quick question.
Yeah, go ahead.
If I have a patient that's in shock but responded to fluids, or hypotensive responded to fluids, his lactate wasn't high, and he has a possible source. You can't call this septic shock, right?
So without
Because I
hypovolemia,
had this situation
sepsis.
before.
sepsis only. So it's part of septic shock without hypovolemia.
But
So if it responds to
It
fluid,
has to have lactate. It has to have lactate of more than 2 or needing pressures. That's it.
Lactate more than 2 would actually volume resuscitated. Like he needs to be
Yeah.
euvolemic at least,
Yes.
according to the definition.
because I had another patient who was CDI sent me he had a lactic acid of 3, and he just improved with fluids. He wasn't even very hypotensive.
Yeah, but because of the lactic
So
acid,
do I call it shock?
by definition.
No, it's
By this
because
definition,
by
yeah.
this
I
definition,
mean-
no, because he gave him fluid, he resuscitated the
No,
volume status.
Look, this definition,
You need-
without
you need-
hypovolemia,
you need-
that does not mean with resuscitation. Okay? So some people will present to you, right, with infection, but they're hypovolemic. Sepsis, by definition, is not a hypovolemic state. It's actually a euvolemic state. So you have to rule out hypovolemia. Yeah, someone who came in with diarrhea for 3 days and his lactate is 3, you don't call this septic shock, right? You correct his volume. If his lactate is still high after you correct his hypovolemia or his bleeding, for example, then that's septic shock. But for someone who comes to you with a pneumonia, he's been eating and drinking, okay, you assess him as euvolemic, okay, and he is hypotensive, you want to give him fluids, this is septic shock. So the definition is that, it's lactate without hypovolemia.
yeah, and we should keep in our mind other causes of
Without
lactic.
hypovolemia or hypotension.
Yeah, you're fine.
Yes, without hypovolemia, yes.
Yeah.
Hypotension is the need for pressures.
Okay.
Okay?
Yeah, we should keep in our mind like other causes of lactic acidosis, like cirrhotic patient, liver injury, they have high lactic acid, and even DNP sometimes lead to elevated lactic acid. Okay, so what's the definition here? So there is no gold standard to define this patient as sepsis. So no diagnostic test can say this sepsis. As we said, it's organ dysfunction. So it's like a syndrome. So at the end is the clinically, it's the thing is we can decide this patient is septic shock, or the patient is just in severe infection. So this algorithm, so we can go over it. So if we have a patient in emergency department or even in the floor, so we suspect infection at this point. So the first things we do is the quick quick SOFA, it's like a new parameter. It's part from the small part of the SOFA. Doesn't need any invasive procedure or a blood test. It's just 3 organs we look to. It's the mental status. The other things is blood pressure below the 100 systolic, and we look to respiratory rate more than 22. Patient meet 2 of those, so then we can assess him for SOFA, if he has septic or not. So quick SOFA, as we said, it's outside the ICU. And increasing the score, it's increasing with the mortalities. And it's designed to be for all healthcare workers. It's not only for the physician, even the nurse and the ED can assist the patient with a quick SOFA. Then after that, we'll go with the SOFA. SOFA has 6 parts. They have 5 major organs. We look to the blood pressure, respiratory rate, we look to the mental status, we look to the bilirubin in the liver, and also what we look for, kidney function, and the platelet, the coagulation profile. If he has met more than 2, so we know at this point his mortality above 10%, then we know he has sepsis. Then we can assess the patient if he has septic shock. So if he needs vasopressors and if his lactate more than 2, then he has septic shock.
Pressors is like the definition of septic shock. You need pressors. Like
Need pressors, yeah.
Pressors or lactate more than 2.
And-
After fluids. After
After
fluids,
ruling
yeah.
out the need for fluids.
Yeah.
Or after
fluids,
giving
continuous
fluids.
Right.
need, that's septic shock.
Right.
But after fluids,
Yeah.
This one, that's
normotensive.
sepsis.
No, I mean after fluids, normotensive patient didn't require pressors, but his lactate is still high.
Sepsis, not septic shock.
Sepsis, because he
No,
has
septic
2.
shock.
Septic
by
shock.
definition, septic.
Yes, lactate more than 2 after fluids
After
is
fluid,
shock.
even though there is no pressors
Yes.
needed. I'm sorry.
Yes.
And it's septic shock.
Go back to your algorithm.
Because saying
by
and,
definition.
That's,
Does it have to be
this,
and?
this was
Yeah.
Yeah, it should be like this.
Both?
pressors.
both, yeah,
It
that's
should
from my
be both.
understanding.
But if he responds to fluids, that's sepsis. But if he required the pressors after you give
no,
him
it didn't
fluids,
require pressors,
so
but his
that- I
lactic is
think
still high.
He didn't like shock on after he didn't respond to fluids and require pressures. That's shock.
It has to be both.
Okay, so
yeah.
it has to be both.
Yeah.
Okay.
This is what he says.
Yeah.
But now they start
Alright.
talking about like giving because this
of what?
30 ml per kg as now this before you will be maybe called and actually one patient like that we had in the ICU called it to pericardial effusion and he had like lactic acidosis. They called you and they send you an email. You didn't give him like these 30 resuscitation because at that time like he had end-stage disease, heart failure.
That's tamponade.
And nowadays they start putting this in consideration, that patient with end-stage renal disease or a patient in heart failure, you might not give this amount of fluids. You need just to weigh things before you start
Yeah.
giving this.
Before you start
you will
pressors
be
early.
blamed and maybe put a question mark why you didn't give this amount of fluid.
Yep. Yeah, and. Okay, so just review what I said. It's bedside test outside the ICU, and it's give you the indication that patient more likely to develop sepsis depends on the retrospective data.
Can I ask you a question?
Yeah,
Can you
sure.
go back
Yeah, sure.
to the algorithm?
Yeah.
Where did you get this from?
I believe one of the studies came with sepsis 3. It's that's called changing sepsis idea. I will get it for you,
Okay.
for sure.
Just get me the reference for it.
Yeah,
I
sure.
think it's or, but that's fine.
Okay, we can look it up. Sure. Yeah. Quick SOFA developed.
One notice.
Yeah,
when
sure.
you get something like this, okay, you always write the reference on the bottom.
Sure.
Especially if you take it out of a source.
Yeah.
Gotcha.
Okay?
Mhm.
You have always to
Future
give credit to the
presentation.
people who made it.
Sure. Okay, that's basically the same stuff I mentioned before. I mentioned QSOFA, it's not diagnostic, it's just a warning sign. Then SOFA, as we talk about it, and the increased mortality with increasing score, and it can reach more than 90% with a score 15 or more. And this is the score. Okay, so one of the study which combined with a septic 3 meeting is the prognostic accuracy of SOFA score, series criteria, and the QSOFA. So this study was done in New Zealand and Australia, adult patient database, or the patient above 17-year-old was admitted to ICU that time, and the primary outcome was in hospital mortality, and the secondary outcome was in hospital mortality plus length of stay in the ICU. And as mentioned there, all the patients, most of them in the SOFA score, they score between 4 5, so they been septic. And on the SERS criteria, according to the previous sepsis definition, score between 2 and 3, and the QSOFA was most of them above 2, which is showing with the mortality that increase with increasing the score, most of these scores. And they found on ORIC that SOFA, it's for sure it's a retrospective cohort study, that among patients admitted to the intensive care unit defined sepsis by increase in SOFA score provided great prognostic accuracy for in-hospital mortality than either SERS criteria or QSOFA. This is why they took SOFA as part of sepsis definition and diagnosed patient with sepsis. Okay. And this is the numbers. Then after that, there's the other study of the assessment of the clinical criteria.
So go back to that.
Okay.
You have a prognostication method of 1, 2, 3 versus a prognostication methods of 1 to 15. Which one has more accuracy?
Well, but this is score 2 only.
I'm saying, when you're talking about accuracy,
Yeah, accuracy for sure is SOFA.
when you are increasing your points within the target, which one has more accuracy? The target that has more
points, yeah.
scores. Okay.
That's why I was interested to look between QSOFA and SERS.
They're the same.
And so QSOFA and SERS are the same.
A little bit QSOFA was better than SERS in the other.
But look at the area under the curve. I mean,
No, here yet, but the other study I will show
I'm just
you.
saying,
Yeah.
they're the same because they have the same number of variables, right?
Right.
Of course, the accuracy will be the same. I'm just.
Yeah, almost. Yeah.
Okay.
Yeah.
But they had to compare it.
Yeah.
It's a publishable.
Publishable, no?
Yeah.
Okay. So the other one was the assessment of the clinical criteria. This was done in Pennsylvania, United States between 2010 2012. And there was among 1.3 million electrical health records, and mainly outcome and measure also the same in hospital mortality for the primary outcome and secondary outcome for in-hospital mortality plus length of stay in ICU more than 3 days. And we say here ICU, there was ICU encounter and non-ICU encounter. And here the result for the ICU encounter, SOFA was better than the SERS and the QSOFA, and in non-ICU encounter, so QSOFA was actually better than SOFA and SERS.
In doing what?
And diagnosis, and the patient, like, to measure like if this patient really need to be shifted to ICU or
So what's the goal? Like what is the end point that they studied?
Go back one slide.
Just-
see your the method. One more. Here.
so the thing is with
In
the,
hospital mortality.
And hospital.
Okay.
Length stay.
so the thing with the QSOFA, which I mentioned, like why is it better in non-ICU patient, because it's less invasive and it can be
Yeah,
used
yeah,
with
of
other
course.
healthcare worker.
So it makes sense.
Yeah, it's easier to
It
get
makes
earlier
sense that it
treatment.
will predict outcomes in outside of the ICU or outside of the hospital because nurses and EMS and it's a quick. I do not have the SOFA criteria in the ER.
Right,
Right? Okay.
that's
Right.
what.
But you always look at what they're studying, what is
Yeah.
the end point. So apparently it will predict mortality better than SOFA because you do not have SOFA.
Well, everything it makes sense.
Okay. I'm just making you look at the data. That's what I want you to look. It's
Yeah.
not just cite it. Oh, QSOFA is better outside and SOFA is
No,
better.
it makes sense
yeah,
even without study.
exactly. So you have
But
to
I
make
mean,
sense of it.
you have to study. Okay. So criteria outside the ICU as what's the possibility of, we'll say it's controversial issues about QSOFA. So in QSOFA, you have to be already know, like we suspect infection in the patient, and the other things, mental status part of the QSOFA, especially with patients you are not really sure about what their baseline, especially with people with dementia. So how the alteration or change, it's not really predictable. And the other things, they tried to add serum lactate to the QSOFA score, but they didn't feel that's making any change, because most of the people, when you suspect sepsis, they're gonna come with lactic acid more than 2 in the beginning, so you're just increasing the score, or just gonna take one of the score. We'll talk about the pathophysiology. So we say sepsis is dysregulation of immune system, which is contain release of pro-inflammatory mediator response to infection, which exceed the boundary of the local environment of the infection to become more generalized in the body. Normally, when we have like bacterial pathogen invades any site of the body, first thing, initial immune system, immune cells try to attack the macrophage, ignite the bind, the microbial, then phagocyte, then recruit more neutrophils, and secrete more pro-inflammatory and anti-inflammatory mediator for that general immune response. But what's happened in sepsis, that will be autoregulation from pro-inflammatories and recruitment more cells, which lead to the damage more than the benefits, which also happened in the ARDS. So as we said, excess pro-inflammatory mediator and the complement activation, also some genetic susceptibility from different person to the other can lead to dysregulation of the autoimmune response, or dysregulation of immune response. So which organ can be affected by sepsis? Mainly all organs. It's starting from brain to the toe, cardiovascular, hepatic, renal, neurological, respiratory, endocrine, and hematology. We'll take a little bit on everyone. Nervous system mainly is like altered mental status, which is part of every criteria to diagnose, but in the same time we have to rule out the hypoxemia, hypoglycemia, and drug toxicity, which can cover the picture. Then we'll go with the cardiovascular. The pathogen is mainly the hypotension, with all these mediators can lead to vasodilation, arterial or venous, myocardial depressions, stress cardiomyopathy. Also with people with coronary artery disease, can we have atherosclerotic induced myocardial ischemia dysfunction, which sometimes can we define it or differentiate between the general one, between the coronary artery disease that's going to be specific ischemia on the different site in the heart. Then the lung, the main things that happened is the acute respiratory distress syndrome and respiratory muscle fatigue, patient needs to intubation, and decrease in the lung components. Renal.
Hey, we're pulmonologists.
Okay,
Yeah.
more
Go
specific
to the
Diagram.
diagram.
picture.
Yeah.
Okay, so
Yeah, it's just, this is so it's important. This is pathophysiology of ARDS and sepsis.
right.
Exactly.
Yeah.
Okay, so first things is we have like the pathogen which became to the alveoli. The first innate immune response will come is the macrophage. The macrophage try to phagocyte the pathogens and start releasing pro-inflammatory.
But you do not have to have pathogens inside the alveoli for that to happen,
Right.
right?
It's insult.
So basically, just the pro-inflammatory state can actually increase the migration of the cells through the capillaries into the alveoli. Okay, and just because of the pro-inflammatory process, you can actually have cascade of inflammation inside the alveoli. Even if you have, for example, the infection in your toe.
Somewhere else.
Okay, so it doesn't have to that you
Right.
should not only have cellular debris or bacteria inside the alveoli for all this to happen, right? Okay.
Okay.
And then basically there's basal membrane damage, right?
Basic membrane damage, increase in fibrogen and pro-inflammatory.
Hyaline membrane.
Yeah, decrease gas
Right.
exchange and
Good.
lactic acid.
This is when you lose your
Acidosis.
surfactant and you develop lactosis and
Right.
blah, blah, blah. Okay.
Next. Renal, so
We skipped over it, so I got mad.
You get irritated.
renal dysfunction that's progressed frankly to renal failures, and a lot of people may need dialysis during sepsis or septic shock condition, which means things like acute renal failure, which could be ATN secondary to hypotension or septic shock.
Now, is that right? I mean, what does happen in the initial phases of sepsis? What kind of changes to the kidney? What happens to the kidney?
Increase of flow, venodilation.
The afferent get vasoconstricted. So decrease the renal flow.
Decrease in flow to preserve the blood pressure.
So there is a big argument about what you just said, loss of intravascular volume in sepsis. Okay, this usually is not the case in septic AKI. Septic AKI is a pro-inflammatory condition, okay? It happens in the later forms of septic shock, where you are hypotensive and you basically decrease your perfusion to the kidney, but the initial insult to the kidneys is actually septic. It's dysregulation of the autoregulation that is happening in the kidney. In the initial phases of sepsis, you actually have hyperperfusion to the kidney, you have increased urine output.
Just try to compensate and then
Yes.
decline.
And then basically the injury and the pro-inflammation causes the damage to the vascular and then the interstitial parts of the kidney. And then at the end, if you go into severe septic shock, then you develop the ATN.
ATN, yeah.
Okay.
Okay. Then hematology is mainly the DIC, the main promoting the severe sepsis or septic shock. GI, it's allowing translocation of bacteria and endotoxin into systemic circulation, and which part of the sepsis, and the acute liver, and also can lead to liver shock with a septic shock with hypovolemia. Endocrine, different part of the hormones can be affected, mainly it's going to be sepsis-induced adrenal insufficiency and hyperglycemia and insulin resistance. Also in men or women, a decrease in sex hormones as a stress-induced hypothalamic. It can lead to amenorrhea. Diagnosis and screening and prevention. As we said, no single diagnostic test. It could be there.
I would love to, if you have touched on the cortisol physiology in sepsis there. But you don't have to, but that's fine. I'm just saying. Okay. I would have loved if you touched on it. Right? Because there's always a debate about it.
Well, I read about it, which is like...
What do you think about it?
It's different from people to the other. Like if you have like 100% went to the ICU. So the main things, there's like pure adrenal insufficiency or poor response from the adrenal gland, or people, they can be just normal with good response. So the people who like having deficiency at all, they will not be having any response or any cortisol secretion at the stress situation. The other people who...
These are the people who have known adrenal insufficiency.
Right? Or maybe it's like masked, but it's like very obvious.
Right?
Yeah. The other people who came in the middle, who have like the poor response for that. So they have like secretion of their cortisol or adrenal hormones
are insufficient.
Insufficient to meet the stress part they are on. And the other part, people who can be just normal.
So what's the pathophysiology for that? Do you know? The people who we call the critical illness related hypocorticolism.
To be honest, I read about it, but I'm not able to extract it from
theories about it, and how it works. It's just because it's a very important topic in ICU. But
there's multiple ways to diagnose it with different cuts.
There's lots of debate about even if it exists or not.
Yeah.
So
it's relative adrenal insufficiency.
It should be a topic on its own.
Right.
Yeah.
Okay. So as I mentioned, there is no good diagnostic test. But with new procalcitonin being used more and more right now, it can give some idea if there is going infection in the patients, and also I'm gonna say it's how much it costs sepsis for any admission. It's like annually cost exceed more than 20 billion every year, and the prevention, it's mainly vaccination.
Just because you mentioned procalcitonin, we gave a presentation about that before.
Yeah, I mean, just here one slide regarding procalcitonin. I found this study was published in China recently. So they're talking about the procalcitonin and how much it could be sensitive in that situation. So mainly it's more specific, it's 98%, and the negative predictive value is 86. So if you have negative procalcitonin, you have like saying it's less likely, but with positive one, it could be from other reason that procalcitonin could be elevated other than the infection, which is not, I mean, which I know it's originally procalcitonin being diagnosed, designed for the people who are getting pneumonia and to monitor the days of antibiotic, how to give for the patient. Then it's being used for different causes, for like bacterial infection in general. If anybody have different
Actually, you need to
idea.
understand the fact that procalcitonin take up to 6 hours up until it starts to become positive.
And
So this is
to die antibiotic use
no,
in this
not
patient.
antibiotic, not
Yeah.
sepsis, not septic shock. Period. Okay. Now it can be useful as a prognostic factor for us in the ICU. Yes. But
And to de-escalate
This
antibiotics.
could
Yes,
and
de-escalate.
de-escalation
not
is that
stop
method.
anymore with this.
Or expect like predict outcome.
And the problem with this study is that they're assuming is sepsis happens only with bacteria.
Yeah, that's part.
It can be slightly elevated in viral infections, chronic inflammatory conditions can cause
Cancer patients,
end stage renal disease.
This is what I'm saying.
patients.
It's like negative one, it can be ruled bacterial infection, but viral infection is be there.
But still,
It's
you
more
have,
specific.
I wouldn't had
No.
my quote on it in the first few hours of sepsis.
Not really, yeah. It's just part of, you can help you with diagnosis if you are just independent, patient's really sick and you can't find like
And if
where's
it's
the spot
completely
of
negative after
infection.
24 hours
It's
or
a-
48 hours, then
It's-
it has a very good, as you said, exactly, negative predictive value.
Yeah.
A very well tolerated negative predictive value. Talk about almost 90% negative predictive value
For
in
virus.
that setting.
For bacteria.
Bacterial
infection.
infection, yeah.
For bacteria.
Bacteria only,
Meaning
yeah.
the need for antibiotics. Okay?
Mhm.
So if it is negative, it's like 90% negative predictive value. Okay, but you have to wait for it.
And there's more information.
You always have to initiate antibiotics, you know, the first presentation.
Yeah. And sometimes in abscess itself, like if you have abscess in the lung or other way, even if it's bacterial infection, the procalcitonin will not be elevated. That's why one of the ID one time told
Yes,
me,
loculated infection.
yeah,
Exactly.
look at the infection, so,
That's
So
done
even
in
when-
osteomyelitis or bone infection.
yeah, so,
Even the chest lectures, I think that's what they mentioned, there is the predictive, I don't know what study, maybe another study, the predictive value wasn't that high. So even if you have
The
a negative,
positive predictive value is not high.
yeah, so even if you have a negative, I mean, if you think there's a picture of pneumonia, it can be negative, you don't have to depend on that, just have to
No,
treat for it.
yes, absolutely, You got always, all the tests,
Mhm.
you have to take it with basically what you see clinically. I see a lobar infiltration, I don't give a damn if the leukocytes are 7 or 19 or 1,
Right.
right? It's a pneumonia, right?
it's a clinical sense at the
Yes.
end, yeah. And as we know, like, negative, false negative, it's, or false positive, it's be high.
There's no test that is 100%. You have always to take it into the consideration with the clinical picture.
There's a study that showed physician doesn't look into procalcitonin. They just do what they feel is more than procalcitonin.
I use it mainly if
De-escalate.
The trend.
if I see the trend going down, I feel safer de-escalating that down, especially if I have negative cultures, you know, when someone is coming to me with sepsis picture or hypotension. So that is how I mainly use it in the ICU.
Well, to be honest, like for me, like even during residency, I depends on procalcitonin, especially with COVID patients who come like with COVID, severe RDS, negative procalcitonin. So I doubt it's bacterial, so I
There's
don't
actually
start
very good
antibiotic.
data about it coming out with the use of procalcitonin in COVID, that it's a very good, it has a good negative predictive value. Yes, and it's safe to withhold antibiotics
Antibiotics.
for people who have been diagnosed with COVID for a few days and it's negative.
Negative,
Yes.
yeah.
You're absolutely right.
So mortality and outcome, we talk the mortality is high and the average annual incidence range from like million to 3 millions, and severe sepsis was similar to 13 to 13.3%, and hospital mortality range between 14.7 to 29.9%. And long-term mortality and outcome, so septic patients not only in the ICU and discharged, it's long pathway you have to take it with a patient. They've been discharged, most of them being discharged to rehab facility, and it's cost billions every year. And this study was done in Germany, and how much it's gonna cost, like septic shock, it's more than 10 billion euro, and for the sepsis and even severe infection every year. And it's showing that people who getting sepsis, how much they getting a new health related diagnosis after getting septic or admitted to the ICU, with average with people who is getting severe infection, 7 new diagnoses, or septic shock also 7, and sepsis 6. So it's high morbidity, not even just mortality on the spot.
You should have changed the euro to dollar. Let's do that
Yeah. So yeah, the aftercare part. And thank you guys.
Thank you. That was a good discussion. Clean.